So welcome to our webinar on vaccine-induced immune thrombotic thrombocytopenia. I would like to start with acknowledgement of country. Today here at the Baker, I am on the lands of the Boon Wurrung people, and many of you will be zooming in from lands of the Wurundjeri people, where the University of Melbourne is located. Especially as scientists, we appreciate that our First Nations people had knowledge systems that have continued for over 60,000 years, and we pay our respect to their elders, past, present, and emerging. My name is Karlheinz Peter. I'm the head of the Baker Department of Cardiometabolic Health at the Medical School of the University of Melbourne, Deputy Director at the Baker Heart and Diabetes Institute, and Interventional Cardiologist at the Alfred Hospital. My research focus is thrombosis, and this fits quite well to today's topic. Tonight's webinar on thrombotic complications of COVID-19 vaccines is very topical, also very difficult, but also unique in regards to the rapidly emerging understanding of the underlying mechanisms, but also in regards to the political dimension of the topic, especially with the increasing numbers of cases of COVID-19 in Australia and here in Victoria. The intention of this seminar is not to induce vaccine hesitancy, but rather to provide a scientific basis for the discussion of this rare side effect and potentially to facilitate early detection and successful treatment. We will have two presentations from excellent speakers, and then we will have a discussion with a fantastic panel of experts with diverse backgrounds. Throughout today's webinars, you can use the Q&A icon to ask questions or add comments if you like. And let me then introduce our first speaker, Dr. James Mcfadyen. He is a clinical hematologist at the Alfred Hospital and a Heart Foundation and NHMRC funded research fellow at the Baker Institute. And he's also a senior clinical fellow and senior lecturer at Monash University and at the Department of Cardiometabolic Health at Uni Melbourne. James trained and did his PhD at Monash, and his clinical and research expertise is in the field of thrombosis and hemostasis, especially in platelet function. He will start the webinar with summarizing the Australian status of VITT and also present data on a patient who we treated together at the Alfred Hospital and where we could demonstrate for the first time a direct platelet activation after receiving the AstraZeneca vaccine. So it's a pleasure for me to introduce you, James. Would you like to share the slides?
Okay, so thanks, Karlheinz, for the introduction. And thanks everyone for zooming in today for, as Karlheinz said, a very topical and interesting talk, I think. So as Karlheinz mentioned, I'll give a bit of a background pertaining to VITT and then be followed by a talk from Professor Greinacher later on, who's really been one of the seminal investigators in this area. So just by way of some brief introduction, this is really the latest global snapshot of COVID around the world. And really over the last 18 months since the emergence of COVID, really it's wreaked untold, I think, social and health and damage across the world. And sadly for us here in Australia, as I think Melbourne, Sydney and the ACT remain in lockdown, those red dots which denote active COVID cases in the world, Australia is becoming a bit redder as we speak. And this is really put into focus and really emphasised the importance of vaccination. So really in one of the great, I think, triumphs of medical science in recent times, when COVID first came to the fore last year or late 2019, there was a great push on to develop vaccines. And we've really been incredibly lucky and fortunate with, some really amazing investigators developing safe and effective vaccines in a really remarkable time frame. And of course, here in Australia, we've got the Pfizer vaccine, which was published here in late 2020 in the New England Journal of Medicine, and also the AstraZeneca vaccine published in the Lancet around a similar time frame. These are the two current vaccines available to us here in Australia. I guess what happened when the vaccine rollout started in Australia, and it was really a cruel twist of fate that COVID-19 was a condition that is very strongly associated with thrombotic complications. It just had to be something COVID related where one of the answers to this problem, i.e. the vaccine, would then be linked to a strange and rare thrombotic complication. So really going back to March and April this year, reports first came out of Europe about this rare clotting complication associated with the AstraZeneca vaccine. And this really then put a really strong focus on what was going on and what were the problems with this. And as I mentioned before, we're very lucky we've got Andreas with us this evening or this afternoon, who's really played a key role in really uncovering some of the key elements to this blood clotting complication. So where we are right now is this blood clotting complication, otherwise known as VITT. It has a few other monikers, TTS or VIPIT, whatever you like, whatever sounds a bit better. This is effectively a newly described thrombotic syndrome, which seems to occur after adenovirus-based COVID-19 vaccines. So in particular, most well described after the AstraZeneca COVID-19 vaccine, but has also been described after the Johnson & Johnson COVID-19 vaccine. Clinically, this syndrome shares some similarities to heparin-induced thrombocytopenia. And this is important for a couple of reasons. So firstly, this is really an immune-mediated thrombotic condition. And as a byproduct of this, the vast majority of these patients have the detectable presence of platelet factor 4 polyanion antibodies. So clinically, the way these patients typically present is with a low platelet count or thrombocytopenia, with thrombosis. And clinically, this seems to have this predilection for unusual sites. So abdominal vein thrombosis, cerebral vein thrombosis, but really can get thrombotic complications in any vascular bed. And really the reason for this is clearly not well appreciated yet. The other really striking feature of this syndrome is a markedly raised D dimer, something that we very rarely see in the ballpark that we see with this condition. In terms of the time frame, this is another interesting, I think, quirk of VITT, and a little bit like HIT, is this concept that VITT tends to occur really after day 4, day 5, after the AstraZeneca vaccine. So we're getting or seeing an IgG response in really what would be deemed otherwise a short time frame. So VITT, like the COVID-19 pandemic, really has really shone a very bright light on, and I'm biased, the most important circulating blood cells in our body. That's the platelet. Okay. So for people who aren't really familiar with platelets, these are small anucleate cells that circulate in our body and really respond with really tremendous alacrity to any breach of the vascular endothelium, and come in and really adhere and aggregate very quickly to seal that breach and really ensure hemostasis. The byproduct of this, of course, is that these cells play a fundamental role in mediating pathological thrombosis as well. The other really important concept, just to maybe introduce as well, is this idea of what's called immunothrombosis. So one of the key things that's emerged in recent times is platelets, in addition to their really classical role in hemostasis and thrombosis, are really essential players in the innate immune response. And this is really important in the sense that platelets play a very important role in coordinating leukocytes, endothelial cells in an inflammatory sense. And the byproduct of this is that these responses play a very important role in mediating thrombotic responses as well. And this, I think, is quite relevant in the context of VITT. So this is a very busy figure, so I apologize. But I think the key point to emphasize here is that activated platelets can do a couple of very important things that are relevant to thrombosis. The first is that they can liberate a range of small molecules, in particular this one here, poly-P, polyphosphate, which can activate the contact factor activation system, so therefore initiate coagulation. Activated platelets combine to leukocytes, and by doing this facilitate netosis, or the extrusion of what are called neutrophil extracellular traps, which again can activate coagulation and also activate further platelets. And they can also play a role in activating the complement pathway and also upregulating tissue factor expression on monocytes. So all of these things can conspire to really play an important role in enhancing thrombin generation, which of course leads to pathological thrombus formation. So when we look a bit closer on a platelet and really speaking to the important immune and inflammatory role of platelets, platelets are the largest circulating pool of the Fc gamma R2 receptor in our body. The reason why this is relevant in the context of VITT, which looks or is an immune-mediated condition, is that platelets can become activated by IgG or immune complexes. So the way this takes place in the context of a platelet is these IgG or immune complexes can bind to the Fc gamma receptor. And at an individual level, a single IgG molecule with a receptor has a low affinity, but they cross-link the receptor, so overall a very high avidity. When this occurs, this really induces very strong platelet activation, which plays a fundamental role in mediating the thrombotic response that we see in a condition such as VITT. The way this takes place in very simple terms, at least, is on the cytoplasmic domain of the Fc gamma receptor. There's an ITAM motif. When you get clustering of the receptors, The ITAF motifs can undergo phosphorylation, which induces downstream signaling, which really results in a large increase in intracellular calcium, which is a fundamental response that underpins lots of platelet activation pathways. This is really a nice diagram just summarizing the different platelet activation pathways that can occur in response to IgG activation. So an enhancement of platelet leukocyte aggregates, platelet aggregation, microvesicle release, and indeed platelet procoagulant function. So really through this pathway, it helps explain in many ways why we get such a profound thrombotic response in a condition such as VITT. So currently where we are, the current paradigm of VITT is that, like I said before, it looks like it's an IgG or immune response. This antibody can activate the Fc gamma receptor on platelets, which then does a couple of different very important things. So the first, it can induce phosphatidylserine exposure on a platelet. So this is negatively charged lipid, which becomes externalized. And that serves as a very important scaffold for the platelet, for the 10As and prothrombinase complexes to assemble to get efficient thrombin generation. It also directly activates the integrin on the platelet, so platelets can adhere and aggregate efficiently, and also upregulates P-selectin expression, which facilitates platelet leukocyte interactions. The other thing which there's some emerging data on is that obviously the Fc gamma receptor is not just expressed on platelets, is also expressed on other immune cells such as neutrophils. And so via these mechanisms, it's also likely that neutrophil extracellular traps play a role in the pathogenesis of VITT as well, which is another mechanism by which the thrombotic response may occur. The end result of this, of course, is pathological thrombus formation in these different vascular beds, be it the cerebral venous sinus thrombosis, abdominal veins, or your more standard garden variety, if you will, deep vein thrombosis or pulmonary embolism. So in terms of currently, what are the treatment paradigms for VITT? There's really two key things that are required in the context of VITT. So first is the initiation of anticoagulation. And currently, and I'm sure Andreas will touch upon this, the current paradigm is a non-heparin anticoagulant. The second core element of this is initiation of intravenous immunoglobulin. So this is some data which Karlheinz alluded to earlier from a patient that we had here at the Alfred Hospital who presented to hospital with VITT that we managed and recently published in the British Journal of Haematology. So this is just a very simple experiment showing the platelet activation profile and platelet leukocyte aggregates in this patient before treatment with IVIG. And what you can hopefully appreciate here in the middle panel is that before treatment, this patient really displayed profound platelet activation as evidenced here by the increase in PAC1 and P-selectin expression at a basal state. And in accordance with this, an increase in platelet monocyte aggregates. Immediately after treatment with IVIG, we saw this nice reduction in their platelet activation and platelet monocyte activation profile, really speaking to the fact that the use of IVIG looks like has a very important role in effectively non-specifically binding Fc gamma mediated platelet activation. In addition to these two core treatments, there's a proposed role currently for a whole range of different therapies to try and either remove the pathogenic antibody via plasmid change, or indeed initiating immunosuppression and try and reduce the production of the pathological antibody. But like I say, these two things here, anticoagulation and IVIG, are really, as it stands, the two key treatment paradigms for now. So in terms of what do things look like in Australia currently with regards to VITT? So this is the most recently available public data from the TGA. So to date, at least, there's been 125 cases of VITT described in Australia. So that shakes out at about 2 per 100,000 doses. So roughly 1 in 50,000 incidents. Now, of course, in Australia, we early on took the precautionary step, I think appropriately, of limiting the use of the AstraZeneca vaccine to the over 50s and then later on to the over 60s, or at least being the preferred vaccine. So obviously we haven't had many cases in the younger age group, given that hasn't been the preferred vaccine. The other thing which I think is important to highlight here with Australia is we obviously came on board with our vaccines a bit later compared to other countries. So we went into this, I think, with our eyes open, knowing to look out for VITT. And Ewan's on the panel tonight, and Vivian Chen in Sydney have really played a really key role in raising awareness and putting together local guidelines. And so I think one of the good things here at the moment is that, treating hematologist is that I don't think we're probably missing many VITT cases in Australia because we're very highly attuned to this complication. With regard to our data to date, 8 cases of VITT have been fatal in Australia. So that's a fatality or mortality rate of roughly about 6%. So this draws the obvious comparison to how we compare perhaps to countries overseas. So the UK is one of the, I think, good comparators in the sense that they've obviously used a large amount of the AstraZeneca vaccine. So roughly 25 million doses of the AstraZeneca vaccine have been administered in the UK to date. And they've had a total of roughly just over 400 cases of VITT. So they're looking at a rate of about 1 in 60,000. The difference, I think, to us are twofold. So firstly, as you can see here, there's a lot more cases in the young age group because they started vaccinating people without any age limit with the AstraZeneca vaccine. That obviously changed later on. The other important difference, and there's possibly some reasons for this which may get discussed later, is that the fatality rate from the UK data, as it stands at the moment, sits at about 16 or 17%, which is obviously a bit higher than what we've been seeing here. So just putting all this into context, and this is just my last slide before I hand over to Professor Greinacher, this is very recent data out of the UK. So obviously, this is a rare but serious complication of the AstraZeneca or the adenovirus-based vaccines. But I think it's probably two important things to put in context. The first thing I'd like to say is that I think the fact that we're picking up these really rare complications is clearly a good thing because it means that there's very stringent surveillance and things in place for vaccine safety. So I think that's an important aspect. The second thing to put into context is just, like I alluded to before, COVID-19 infection has a very strong association with thrombotic complications. And indeed, this study out of the UK recently demonstrated that if you looked at patients and their follow-up 28 days after either COVID-19 infection versus the AstraZeneca vaccine versus the Pfizer vaccine, and looked at these different complications shown down here, what you can appreciate is the blood clotting complications seen after COVID-19 vaccine were a lot more common after COVID-19 infection than it was after getting the AstraZeneca vaccine, which I think is an important context just to put at the end of my talk here. So on that note, I'll finish up and I'll hand over to Professor Greinacher, who will no doubt provide us with lots of nice, new and exciting information regarding VITT.
Yeah, thanks, James, for a fantastic overview on the Australian situation and especially the comparison to the UK. It's now a pleasure for me to introduce our second speaker, Professor Andreas Greinacher. He's head of transfusion medicine at the University in Greifswald, which is in the northeast of Germany at the Baltic Sea. Andreas Greinacher is known for many years now, I would say, as the international expert on heparin-induced thrombocytopenia. And it is actually this background that has enabled him to be amongst the first scientists describing VITT. And I would also argue he is the scientist who contributed most to the understanding of this rare complication of COVID-19 vaccines. In an interview about his career, he was asked what he sees as his greatest achievement, and he answered being able to collaborate and work together with other experts and being able to build long-lasting friendships. And I think indeed, when you look at Andreas's publication, you realize that this networking ability has been essential for his breakthrough findings in HIT and most recently in VITT. And you will find several of these findings actually published in the New England Journal of Medicine. So it's a pleasure for me to have you here. Welcome you, at least virtually, here in Melbourne. You might be muted, Andreas.
So I'm now unmuted.
Yeah. All good.
Sorry for the technical error. So Karlheinz, thank you very much for the very nice introduction. And you probably mentioned the most important aspect of what I will present you during the next half hour. I have the privilege to present the data, but the results have been obtained by a collaborative network of more than 65 physicians and scientists. Many people of co-workers of my department who, especially during the first weeks, worked 18 to 20 hours per day to get these data summarized. And just as to give you the impression what was going on here. I got the first information on Saturday. This was March 13, when Sabine Eichinger from Vienna called me that she had one of these weird patients, and she would like to discuss with me because it looks like it, but it's definitely something different. On March 15, the regulatory body in Germany, the Paul-Ehrlich Institute, called some experts together describing the first 5 patients. And then we received the first patient sample into the lab in the afternoon of March 16. And March 17, Wednesday afternoon, we found that it is a PF4 antibody and that it is FC receptor dependent. And then we worked through more or less 20 hours per day, including the weekend. And on Monday, the manuscript was submitted to the New England Journal and finally published on April 9. So it was, I've never experienced such a timeline of breakthrough research and work, and you may imagine what an extremely unusual situation this had been. But now I would like to summarize what we know in the moment. I will present several non-published data. Some of them are in preprints, others are just from the lab bench. These are my conflicts of interest, which do not affect what I will report and present today. The structure of my talk is threefold. I will go into the known, which is with presentation. You have already heard some of this. I will draw some parallels to heparin-induced thrombocytopenia, as I'm convinced that both entities have a lot in common. And then I go into the mechanism of with what we know until now. And at the end, I will touch the unknown, the speculation, but I would like to hint hematologists to some other aspects which we have not addressed yet sufficiently, and where I think they need the attention of hematologists and immunologists. Soon after the first patients have been observed, 3 papers came up in the New England Journal from the Norwegian group, 1 from the British group, and 1 from our group. But the best summary and comprehensive presentation of these patients is given in the August paper of the New England Journal from Sue Pevert from the UK, because they summarize there the many patients in the UK, and this is probably the best epidemiological evidence on the clinical presentation of these patients. Although with the presentation of some of the exceptional presentations, I'm currently a little bit uncertain whether they all are really VITT or probably coincidence of 2 different entities. As you have heard before, thrombocytopenia is a hallmark in these patients, but it can range in a wide range from below 10,000 to above 100,000, and unusual thrombosis are frequently present. The onset of symptoms was the key observation helping us to think about an immune response. Patients present between day 5 and day 20. There are reports of later presentation, but again, if one really goes into the details of these patients, they might be coincidence of some other entities. One example of this are patients who develop thrombosis after vaccination, probably a week later, with no thrombocytopenia. And then they receive heparin. And we have now observed a few patients who then developed heparin-induced thrombocytopenia, which is sometimes mixed up with late presentation of VITT. Beside the AstraZeneca vaccine, also the Johnson & Johnson vaccine is inducing a very similar clinical syndrome, presenting with the same features, and more or less the antibodies seem to be very similar. We still don't know whether they are identical, but the mechanisms behind seem to be very comparable, which is hinting that the adenoviral vector is the common pathogenetic cause of the problem. The prevalence of VITT is interesting. For the AstraZeneca vaccine, the prevalence has been described between 1 in 100,000 to 5 in 100,000. The highest numbers are originally reported by the Norwegian group. And the reason for the high number is that these patients were all healthcare workers in a small country, and the underreporting rate is probably low. The second reason for this is that the individuals being vaccinated, the whole entire cohort, consisted of young people, and James has already hinted towards the fact that the problem seems to be more an issue in younger individuals. And in fact, the latest safety report of the German authorities also reports an incidence of 5 in 100,000 in young men who had been vaccinated with the AstraZeneca vaccine, and the highest risk group seemed to be between 20 and 35 years of age. The incidence of the Johnson & Johnson vaccine-induced VITT seems to be considerably lower. It's difficult because the reporting rates of adverse drug effects are different in different jurisdictions, and it might be that part of the lower rate is underreporting, especially in the US, but we speculate that the composition of the vaccine plays a role here as well. The UK had now more than 400 cases, and what has already what has been reported at the beginning, that there's a preponderance of women, only reflects that the healthcare systems usually have many more women employed than men, and therefore the cohort at risk were more women, which caused the preponderance of women. And the overall case fatality rate in the UK was 18%, which is more than double as high as in Australia. And if compared to the mortality rate of about 50% in the first case series, this reflects that our current approach of diagnosing and treating these patients is probably reducing the risk for very severe outcomes considerably. CVST and other major thrombotic events are frequent, and that there is a difference between age groups is an evolving theme, and the reason for this is currently still not clearly defined. Usually the best epidemiological data are coming from the Scandinavian countries because there the entire health record is publicly available, and the Scandinavian countries found increased risk for venous thrombotic events with the vaccine, but not for arterial thrombotic events, with outstanding higher risk morbidity ratio for cerebral vein thrombosis. Also, very soon after the first patients have been reported, the international societies came up with treatment schedules. That's a busy slide, and I only want to focus on the lower part because the diagnosis here is entirely based on clinical presentation and the PA4 heparin ELISA. And on the right-hand side, you see the German guidelines also from March 21. And without going into the details, the lower part is much more complex because we right from the beginning built in the functional test and differentiated treatment according to whether the serum is inducing platelet activation in the presence of heparin or not, or only in the presence of PA4. And now we are coming into the lab testing. Those patients have high titer anti-PF4 heparin antibodies being detectable with commercially available ELISAs, but not all ELISAs work the same. I go into this a little bit later. This is inhibited by high concentrations of heparin. But other than for heparin-induced thrombocytopenia, these antibodies also bind to platelet factor 4 alone. The British group nicely worked up that different commercially available ELISAs show different sensitivity for these VITT antibodies, and that the rapid tests obviously don't work. And very simply spoken, all tests which work on ELISA plates seem to work reasonably well. All tests working with beads seem to be insensitive and missing, and this indicates that the conformational change of PF4 by linking to a certain solid phase plays an important role. This has been confirmed by the French group, finding more or less the same results. So the current knowledge on lab testing is ELISA plate assays work, but one has to be a bit careful with the sensitivities, and the rapid tests are usually insensitive and cause false negative results. And one of the reasons that several patients had been mistreated in Germany during the first weeks was that this knowledge was not spread rapidly enough in the country, and therefore patients had been misdiagnosed and not treated correctly. Hit antibodies and VITT antibodies are different, and the Canadian group in John Kelton's and Donny Arnold's lab identified by an elegant point mutational approach using different mutated PF4s that the VITT antibodies bind to this red surface, which is identical or mostly overlapping with the part of PF4 to which heparin binds, while the Hit antibodies bind to the bluish dots here. And this already shows that these antibodies might be a little bit different, and for certain it is understandable if the binding of PF4 to a solid phase for the diagnostic tests is involving this part, then the assay is insensitive for the VITT antibodies. But this raised major concern. We were working since a long time on the interaction of PF4 and heparin, and we know the heparin binding site of PF4 quite well. And even before the Canadian data came out, we realized that the heparin binding site of PF4 shares very much similarities with a certain epitope in the spike protein. So the question raised, could it be that the spike protein itself is inducing these antibodies, which are then cross-reacting with PF4? And this would mean one should have to change the entire vaccination constructs. But this is not the case. We unraveled this by classic immunohematology technologies. Here are COVID-19 patients tested for the spike protein antibodies, which are present, and few of them have also low titer anti-PF4 antibodies. The VITT sera look different because they have both. They have anti-spike protein antibodies, not a surprise because they had been vaccinated, but they also have the strong reacting anti-PF4 antibodies, which now raised the question, are they cross-reacting? What we did was then affinity purifying the anti-PF4 antibodies by immobilized PF4 from the VITT sera, and then testing them with the spike protein. And if they would cross-react, they should react with the spike protein. But as you can see here, there's absolutely no cross-reactivity. So we are now very certain that the anti-PF4 response has nothing to do with the spike protein. Now, this has become clear also from the epidemiological data, but in March, this was one of the burning questions. When we now have all these ELISAs, should we screen individuals who had been vaccinated for these antibodies to recognize those being at risk, or should we even test individuals before vaccination? There's a mistake. These data are available in blood, no longer under review. And the important finding was whether we use the mRNA vaccinated individuals from a prospective healthcare vaccination study in our hospital or the AstraZeneca vaccinated individuals, we found in about 5 to 8% of them anti-PF4 heparin antibodies, but usually in relatively low titers. Only in one of them, the titer was very high. So the take-home message from this is that the pathogenic platelet activating antibodies that cause VITT occur very rarely following vaccination. And I have to say that those healthy individuals who had a positive ELISA test were all negative in the functional test. All hematologists, but also the standard laboratory, should be advised to interpret the positive PF4 polyimmune assay without clinical symptoms with very much caution, and it doesn't make any sense to screen asymptomatic individuals after vaccination against COVID-19. This would probably only lead to anxiety and potentially even over-treatment. And this is not very much different to what we know from screening individuals, let's say after cardiac surgery, for anti-PF4 heparin antibodies to recognize HIT when there are no clinical symptoms. It doesn't make sense to screen the antibodies. The washed platelet assays are the ones which are relevant for diagnosing those patients. These were the first index patients, and you see a different pattern of platelet activation. The reaction time until activation is our readout for the strength of the antibodies. It's an inverse scale, so as shorter the reaction time, as stronger is activation. And some of these patients activate platelets in the absence of anything. Others require platelet factor 4, and then they strongly activate platelets. And the second column already gives an important hint. When we edit heparin in the typical concentration, which is inducing massive platelet activation or enhancing platelet activation in HIT patients, the reactivity of these antibodies decreased. We now know why this is the case. Remember that the Canadian group found that heparin is binding to the antibody binding site for the VITT antibodies, and thus it outcompetes binding of the VITT antibodies. In addition, heparin is causing a small conformational change of PF4, and this may also contribute to this. What they have in common is that high concentrations of heparin block everything, and this was important and already built in the first series of experiments we performed. When we added high-dose IVIG, the reactivity could completely be blocked. And on the right-hand side, you see the same experimental setting, only in a larger series of patients who all show a very similar pattern. And this observation that IVIG was blocking the reactivity was the rationale for recommending right from the beginning, after, let's say, 3-4 days after observing the first patients, that IVIG should be used as early as possible to interrupt the platelet activating process. And in the meantime, this has become a mainstay of treatment, at least in Germany. The French group of Yves Correl confirmed these data when they used VITT sera. Some of them activated with buffer. Heparin is inhibiting the reactivity, and when PF4 was added, this is enhanced, while heparin is again also inhibiting the reactivity in the presence of PF4, and this is Fc receptor dependent. So in summary, for the functional tests, washed platelet assays plus PF4 work. Washed platelet assays plus heparin are insensitive and false negative. In fact, we are now using the negative test in the presence of heparin to decide whether this patient can be treated with heparin, and we can only refer to case observations and case series, but it seems to work reasonably well. And this is helpful in those patients who have in combination sinus vein thrombosis and cerebral bleeding, where some of the newer non-heparin anticoagulants are really difficult to dose and to manage. Because washing of platelets is restricted to specialized laboratories and not widely available. Stefan Handke and Martina Wolf, a medical student from our group, then started to transfer the functional test to a flow cytometry whole blood assay. And it seems that this assay works reasonably well. And the explanation for this is, I know that several HIT experts are now in the audience. The VITT antibodies are so much stronger than the HIT antibodies that they overcome the limitations of the whole blood assays. But this assay needs addition of PF4, and please be aware there are several PF4s on the market and not all of them are really well prepared, because PF4 is a really tricky protein and one has to know which PF4 source one is using, and the assay sensitivity strongly depends on this. So the VITT pattern is thrombocytopenia and thrombosis 4 to 20 days. In parentheses, probably even longer after vaccination with an adenoviral vector-based SARS-CoV-2 vaccine, strongly positive PF4 heparin ELISAs, but the rapid tests don't work, and it depends on Fc gamma-mediated platelet activation in the presence of PF4. Now, the question is, do we really need laboratory testing for anti-PF4 antibodies, or shouldn't be a new thrombosis with a low platelet count and a high dimer enough for treating immediately? Certainly with the dramatic courses of these patients, this might be very reasonable to start treatment upon clinical suspicion. But there are many parts of the world in whom no anti-PF4 tests are available, and majority of them depend on the adenoviral vector-based vaccines. And the Brighton collaboration had therefore an interim case definition that they say it must be thrombosis and thrombocytopenia syndrome. Any patients presenting with both acute venous and arterial thrombosis and new onset of thrombocytopenia and thrombosis is sufficient to define TTS or VITT. And depending on how the thrombosis is detected and confirmed, they have different levels. In collaboration with the Paul-Ehrlich Institute, we now assess the specificity of the Brighton case collaboration, and they matched all our lab results with the mandatory adverse vaccination reports they have. And the interesting part is our lab approach has a very high sensitivity, but a lower specificity. And when we further assessed those cases where we had a positive lab test, but who did not fulfill the case definition, then all of them had thrombocytopenia, but already not a thrombosis yet. And this is now a really important information. And there will be next week a publication in a major journal, which does not allow me to disclose which it is, where we will further publish these data. So we assume that the Brighton case collaboration case definition needs to be refined and revised. And this 40-year-old previously healthy female shows the relevance of this. 7 days after her first dose vaccination, she presented with a severe headache, reduced platelet count. The dimer was not tested at that time. CVST was ruled out by CT scan, and the patient was sent back home. 3 days later, she was readmitted. severe Glasgow coma score, thrombosis of the jugular vein and pulmonary embolism, platelet count of 35, high D-dimer, cerebral hemorrhage, which in my opinion was secondary. And we have now identified a whole series of patients who all show the same pattern. They present with severe headache, high D-dimer, moderately to low platelet counts, and all of them who were not treated with anticoagulation or IVIG developed within the next week cerebral vein thrombosis or other very severe thrombotic complications. While all those patients who immediately were treated, then like a VITT case, had no further major complications. And I think this has very fundamental clinical implications for management of those patients. So what can we say currently on treatment of HIT? International guidelines recommend IVIG, steroids if the platelet counts are below 50,000 per microliter, and to avoid platelet transfusions, and heparin. In our opinion, if one has a functional test which rules out platelet activating heparin-dependent antibodies, heparin can be used, but this might be a matter of debate. And as long as this assay is not performed, non-heparin anticoagulants should be used. IVIG is clearly a mainstay of treatment. Additional treatments are plasma exchange if the platelet count is very low, because those are the most affected patients. Eculizumab might be worked, protein kinase inhibitors on theoretical reasons, and certainly mechanical thrombectomy. So, as my first summary and conclusion, VITT is caused by anti-PF4 antibodies, occurs between 5 and 20 days after vaccination. Thrombocytopenia, thrombosis, and high D-dimer are typical. CVST and spontaneous vein thrombosis are frequent. Microtiter plate assays detect these antibodies. Functional assays confirm it. VITT can occur as thrombocytopenia only and then requires therapeutic dose anticoagulation. It can manifest as major bleeding, most likely as secondary bleeding, probably of microvessel occlusions. And treatment is anticoagulation, IVIG, and probably some others. Yesterday, this paper from Linda Schönborn is the first author from our group, came out. We then followed all the VITT patients diagnosed in our laboratory who survived for the next weeks and months. And the platelet activating anti-PF4 antibodies are decreasing like they are decreasing in heparin-induced thrombocytopenia. The ELISAs stay much longer positive, but if the serum is diluted, one can also see that the ELISAs decrease. It's simply a ceiling effect of the ELISAs, which don't have a wide detection range of high titer antibodies. And this has, in my opinion, several major implications. And one of the most important is don't shorten the time between two vaccination shots, because we also have preliminary evidence that there are individuals out there who have platelet activating anti-PF4 antibodies after the first vaccination, but who are still asymptomatic. And I have no idea what happens if one is giving the second dose while platelet activating antibodies are still circulating. But after 3 months, which is the originally recommended distance between two vaccination doses, the likelihood that there are still platelet activating antibodies present is extremely low. The second implication is we were then following these patients and ask whether we can vaccinate them a second time. We used an mRNA vaccine, and none of them developed any further complications after the second vaccine shot. And this allows them to be fully vaccinated against COVID-19 without the risk of recurrence of it. And at least for the affected patients, this might be an important information. Now I would like to come to the more pathophysiological implications after working through the different clinical aspects of it. VITT has a lot of parallels to autoimmune HIT, and those who would like to read more of them, I still think that this review article in JTH a few years ago summarizes most of the pathogenesis. What all HIT researchers know is that many HIT antibodies have no clinical relevance. There's only a subgroup which is causing thrombocytopenia and thrombosis. And since a few years, we know about autoimmune HIT. These are catastrophic antibodies causing major complications independent of heparin. And everything and all these VITT antibodies are similar to the autoimmune HIT antibodies. They are no longer the tip of the iceberg. They are the flag on the tip of the iceberg. And this is where we should focus on thinking about the underlying mechanism. And we don't know what is the cofactor which is inducing the problem in HIT. And you remember that I just recommended that the distance between 2 vaccination shots with the AstraZeneca vaccine should be kept for the 3 months. And this is primarily based on the assumption that if the cofactor is added while the activating antibodies are still circulating, one might cause trouble. What is the underlying cause of autoimmune HIT? PF4 is strongly positively charged and repels each other. And this is shown here by atomic force microscopy showing single PF4 molecules. When von der Perrenox, a small heparin, is added, the PF4 molecules come closer together, but they don't form a certain structure because each PF4 is saturated. When heparin is given, it bridges PF4, causes a conformational change to which then the antibodies bind. And the autoimmune HIT antibodies make exactly the same. They bind to PF4, bridge 2 molecules, open the conformation. So in HIT with heparin, we see this ridge-like structures here by atomic force microscopy visualized. And the autoantibodies in HIT, and to my opinion also in VITT, cause more or less the same structures by bridging several PF4 molecules, which then allows other antibodies to bind and to form large immune complexes, which are then massively activating platelets. There's a second feature of HIT. A prospective randomized study in surgical patients, trauma surgery patients in our hospital. The surgeon was the same, the nurses were the same, the heparin was the same, the treatment duration was the same. The only difference was that the one group underwent minor surgery, the other major surgery, defined as the large bones, the pelvic and the spine. And the immune response was more or less restricted to those undergoing major surgery. Thus, B cells producing HIT antibodies require co-signaling and a danger signal. And I'm absolutely certain that the same accounts for the VITT patients. The anti-PF4 heparin response is very weird. One can induce it also by polymicrobial sepsis in mouse models. And when we treated PF4 knockout mice and challenged them with bacteria, they produce beautiful anti-PF4 heparin antibodies. The same is when we take cord blood from newborns and stimulate these B cells ex vivo, they produce beautiful anti-PF4 antibodies. Thus, we assume that at least the IgM antibodies against PF4 and PF4 complexes are natural antibodies. And remember what I have shown you just before, that the immune response is transient, that these high titer IgG antibodies disappear within 3 months. This again hints towards a special population of B cells being involved in the immune response. And most likely it is like in HIT, marginal zone B cells being responsible for this immune reaction. And this now leads to our current understanding of the concept of pathogenesis. The concept is structured into 2 parts. The first is inducing the antibodies, which requires antigen formation. And this is induced by PF4 interacting with the vaccine and vaccine constituents. In addition to this, an immunological danger signal is required to trigger the involved B cells to produce these antibodies. And then comes the second part, at least 1 week later, when enough highly pathogenic antibodies are formed, that they can then activate platelets and other cells to induce a prothrombotic state and amplification of thrombin generation. And this then leads to the clinical picture of VITT. And the first and the second part are independent of each other. The antigen being present during the first days will no longer be present during the time point when the clinical symptoms and problems occur. These are more or less autoantibodies. So how is the antigen formed? And most of these data are in the public domain as a preprint since April this year, because we immediately released them, but we struggle still with reviewers to get this data published. What we did by DLS, dynamic light scattering, was to measure the size of the vaccine particles. The vaccine itself has 19 nanometer particles, which is a typical sign of a size of an adenovirus. When we added PF4, they became bigger. When we added a monoclonal antibody against PF4, the complexes became even bigger. And when we used affinity purified anti-PF4 antibodies from the VITT patients, they showed the same size increase as the monoclonal antibody, strongly indicating that these antibodies bind to vaccine or vaccine constituents. And now comes a really important experiment. When we then added DNA, these complexes became huge. So DNA is one cofactor facilitating complex formation and antigen formation, antibody binding. And all of this is charge related because heparin is disrupting this. By super resolution microscopy, we could then see PF4 in green label with particles of the vaccine in magenta forming complexes. They always attached to the outer side. But super resolution microscopy is great. And we could even see relatively large complexes of vaccine constituents containing the hexon protein in green, PF4 in green and the hexon protein in magenta. And we are really proud of that the bluish dots are a label of the VITT antibodies directly binding to these complexes. You remember the schema I've shown you for the pathogenesis of autoimmune HIT. This looks very, very similar of what we have visualized for autoimmune HIT. Therefore, I think there are these major similarities. But when we looked by electron microscopy, we found the virus in the vaccine, but a lot of other stuff. And when we then added PF4, large complexes were formed, but not with the virus. The complexes were formed with this amorphous material. And these complexes contained adenovirus vector proteins, especially the hexon protein, and they contained PF4. And we have, for technical reasons, we have to show them on two separate micrographs. Also by super resolution microscopy, it's clear that the virus and virus constituents bind to platelets. And we currently assume that platelets are the shuttle which bring the vaccine and PF4 towards the B cells and inducing the immune response there. But where is the co-inflammatory signal coming from? When we assessed the AstraZeneca vaccine by silver scale gel, we found a lot of bands, very unusual for a vaccine. And by proteome analysis, we found constituents of the vaccine, and all the blue dots are the chimpanzee virus proteins. The red dot is the spike protein, which is not a surprise because the vaccine, the vector is a bit leaking in the cell culture. But what is most important, the gray dots are all proteins of the hex cell line in which the virus is propagated. And of the about 70 to 80 micrograms per ml proteins in the vaccine, nearly half of them are human proteins, which are, let's say, constituents, contaminants from the cell line. Also, the vaccine contains a lot of free hexon proteins because the absolute weight of the adenovirus would be 12.5 micrograms, and we have the human proteins would account for about 20 micrograms. So there must be a lot of free hexon proteins. And the cell constituents of the cell culture plus the free hexon proteins, in our opinion, are the triggers which are inducing an immunological danger signal by triggering the innate immune system. And there comes an additional cofactor, which is EDTA, which is in the vaccine. EDTA in the vaccine and the vaccine are inducing capillary leakage when we inject them into mice in a skin model of mice. Why is this? Capillary integrity is caused and maintained by VE catarrhine lining of endothelial cells. And this is calcium dependent. EDTA is complexing the calcium. The capillary endothelial cells then open gaps, and vaccine constituents can diffuse into the vascular system. And in these mice, we found PCR chimpanzee DNA half an hour after injecting the vaccine into the skin in all organs, including the heart and the spleen and the liver. And I myself have been vaccinated with the AstraZeneca vaccine. And the first day after vaccination, I didn't feel very well. Half of our co-workers who got the vaccine had to take a day of sick leave after vaccination. And some individuals even form these skin reactions typical for immune complex disease. And this is probably the danger signal, and that this is not restricted to the mouse skin model where we had an artificial system with intra-skin injection. We now performed the zebrafish model in which we injected the vaccine into the muscle to better reflect what is happening in vaccination. And we did see exactly the same. Both EDTA and the AstraZeneca vaccine immediately caused increased leakage. Now I have shown you that these antibodies require PF4 to activate platelets, and that DNA is enhancing this effect, not only complex formation, but also platelet activation. So the question was, where is DNA coming from in the human system? And DNA comes clearly from neutrophils. When neutrophils become activated, they release DNA. And now we performed a whole series of experiments together with Thomas René from Hamburg, incubating platelets with neutrophils and measuring netosis. And that this happens also in the VITT patients is shown by measuring cell-free DNA, MPO, and now citrullineated histones, which are strongly increased in VITT patients. We were also able to further work up these intracerebral thrombi of these patients, which show a lot of nuclei, and by immunohistochemistry, these thrombi contain a lot of neutrophils and a lot of nets. So for the last minute, I will now get into the unknown. And I would like to stress that this is a hypothesis, that I don't have data. I don't want to cause anxiety, but I would like to encourage those scientists working in the field to also address this issue. I've shown you that the AstraZeneca vaccine and various lots contain a lot of contaminating proteins from the cell line. And there are also green dots I haven't got into yet. And the green dots are membrane proteins. Several of intracellular membranes, but also some of outer cell membrane. The cell line results from one individual, and individuals have polymorphisms. So we inject a lot of polymorphic membrane proteins with the vaccine. And at least we know from the veterinarian area that when same species protein contaminants are in vaccines, they can induce alloantibodies, which later can induce fetal-maternal incompatibility. And this aspect has not addressed at all. And I like to urge immunohematologists to take a deeper look into this, because we can't do everything at the same time. So in summary and conclusion, VITT is caused by anti-PF4 antibodies. Human proteins and EDTA in the vaccine likely contribute to trigger the immune response to PF4. Anti-PF4 autoantibodies activate platelets, and activated platelets recruit granulocytes. Netosis amplifies the reaction and causes a thrombin burst. What is currently unclear is whether the vaccine induces an immune response against other proteins, but again, this is a pure hypothesis. As I mentioned at the beginning, I have the privilege to present these data, which have been generated by a huge network of scientists, mostly in Germany, many in Greifswald, who pulled all their forces together to present the scientific and medical community these data. And we hope we could contribute somewhat that the rare adverse effect of VITT could be better managed in individually affected patients. But probably the most important is that we may have contributed to reduce anxiety, because now patients and the public knows that researchers and physicians have an idea what is going on, and that they can take appropriate measures to counteract the very rare adverse effects, and therefore can reduce anxiety. And I would thank you very much for your attention.
Thanks, Andreas. What an excellent talk, and congratulations to an amazing body of work. I think there are probably a lot of questions, so please, the audience, if they are interested, just post the questions on the Q&A. Then I would like to introduce the panel. We are really quite fortunate to have a panel of experts here, and I would like to introduce each of them. So the first one, Kanta Subbarao. She's director of the WHO Collaborating Center on Influenza and professor at the Department of Microbiology and Immunology at the Doherty Institute here at Melbourne. She studied in India, trained as a physician in children's infectious diseases, and has had then a career at the NIH and the CDC in the US. And her expertise in virology is sought after here in Australia, but also worldwide. Our second panelist is Professor Huyen Tran. He is Director of Hemostasis and Thrombosis at the Alfred. He studied and trained at Monash and did a fellowship at McMaster's in an internationally well-known thrombosis unit. He co-founded the VITT advisory group at the Thrombosis and Hemostasis Society here in Australia, and he serves as the hematological expert on VITT on the Australian Technical Advisory Group on Immunization at HAGI, and also the World Health Organization. And then finally, our third panelist, Liz Gardner. She is Deputy Director at the John Curtin School of Medical Research at ANU. She trained at Monash, did a postdoc at the Cleveland Clinic, and then actually came back to Australia and worked initially at the Baker, then at Monash, before she moved to ANU. Her research focus has always been on platelets and their surface receptors, including their involvement in HIT and also in VITT. So what I thought doing is having a first question to Kanta. One of the issues that we see here is that both Johnson & Johnson and the AstraZeneca are adenoviruses, but we have also other adenovirus vaccines available, the Russian vaccines, for example. So what do you think is the situation? Is it specifically to these adenoviruses? And this is a question especially drawing on your expertise, whether thrombotic complications have been described in other vaccination programs.
So yeah, thank you for the question. Actually, thank you for the phenomenally informative talks that went before. So I really think that the observations of VITT have followed the AstraZeneca Chimpagno vaccine, as well as the AstraZeneca, as well as the Johnson & Johnson or Janssen vaccine, which has Ad26. There is at least there are two other adenovirus vaccines for COVID-19. One is the Russian vaccine made by Gamaleya, that is a combination of two adenoviruses, Ad5 and Ad26. And the second is CanSino, which is a Chinese vaccine that has adeno5 as the vector. So I think we really, in fact, the question in my mind is how much are those two vaccines being tracked for these observations for VITT? Because I understand even when you look globally, the AstraZeneca vaccine, whether it's manufactured directly by AstraZeneca or by partners like Serum Institute of India or Korean manufacturers, are being widely used around the world. And we're not yet seeing reports in the same numbers of it from countries like India and Thailand and so on. So and similarly, both the Gamaleya vaccine and the CanSino vaccine are not being used in countries that have reported a lot of it, because the choices of vaccines that different countries have made or what's available to them is quite different. So I think, you know, it's a cop-out answer, but I think that we really have to wait for the data. It does certainly look like adenoviruses are play an important role, but whether all adenoviruses are equally likely, and of the other two vaccines, certainly Ad26 is part of the Gamaleya pair.
So would you think it's the production process using HEK cells, for example, or is it actually the adenovirus structure itself that causes this?
Well, what we just heard from our speaker suggests that it is the cells. And I think that the types of experiments that he showed us would have to be done with these other products to in fact see if there's that same, you know, large amount of human protein present in those vaccine products as well.
Yeah, okay, thanks very much. Then I have a question in regards to the localization. These thrombosis events are at very strange localizations in the brain and in abdominal veins. So is there any explanation for this?
Thanks, Karlheinz. I think the short answer is that no. Not that we currently understand. You know, there's various theories being thrown around that potentially there may be differences in the lipids that demonstrate predilection to some of these more atypical areas. And, you know, as I think it's pointed out by James and Professor Greinacher, is that, you know, the more severe atypical forms of VITT that is involving the splanchnic circulation or the CVST tends to be occurring more commonly in the young is our observation, and I think that's similar elsewhere, and certainly in Australia as well. I think early on, you know, we saw a slight male preponderance. But I think in the recent wave that we've seen in New South Wales, Sydney, and in Melbourne, and as we vaccinate more younger people with the AZ vaccine out of need, we are seeing, you know, more severe cases swinging towards the female.
Yeah. And one other question that Andreas more or less also touched on is the question of heparin treatment. The AstraZeneca vaccine will be available in a lot of third world countries, and where there are not these advanced anticoagulants that we have available in Australia and many other countries. So would you then suggest that we start with heparin without any test that often is also not available? Ian, would you like to?
Oh, sorry, I thought that question was a direct answer. Yeah, so I think that's a really fascinating question, and I think, you know, based on the findings that's been reported out of the Canadian lab of the competitive binding side of heparin, and, you know, some of the data showing that heparin may, you know, reduce the activation of the platelet. I think that in dire situation where you don't have the availability of these non-heparin drugs, and I think you might have to commit to giving some people a heparin drug. But, you know, I think there's a question on the line there that in some instances, we do see potentiation of the platelet activation with the addition of heparin, but you know, not every place, every country will be able to do that test to be able to separate out between the two differences. So I think it's very tricky, and certainly lower and middle income countries where apixaban and rivaroxaban, for example, are not available. I think if you have a very sick patient on your hand with a thrombosis or CBST, I think you may have to committing to giving heparin anticoagulation in the first instance, and then, you know, switching them to warfarin as soon as you can, if that's possible.
And maybe a question to Liz. I mean, obviously platelets are centrally involved in the pathogenesis. So why don't we discuss anti-platelet therapy like, you know, aspirin or clopidogrel as a potential way forward?
Or even more targeted, you know, some of these new reagents that attack the signaling pathway that Fc gamma R2A employs, such as inhibitors of SYK and Src kinases. So actually the clinicians, James, Ewan, Andreas, can possibly feed back more on that. There's anecdotal evidence of success with these reagents in HIT. So, you know, there is some rationale there. If I could just follow up a little bit on what Ewan was saying about the uniqueness of the vascular beds, it's possibly a clue that we have here. And I'd be interested in what Andreas thinks about. These are low shear environments, generally speaking. So there's a lack of shear stress, generally speaking, in these areas. There's also, I've heard it, or it's been written in one of the miles of literature, there's a preponderance for bacteria in these vascular beds too. So I've asked anyone on the panel, and Andreas, you and James, what about a SYK inhibitor?
Yeah, SYK inhibitors might work as they block the Fc receptor signal transduction. They work in vitro. I don't know any clinical data using them. I would always combine them with an anticoagulant. But one note of caution to what has been discussed before. I would not switch to warfarin as soon as possible. We know from the HIT story that in situations where we have immune complex mediated exacerbation of thrombin generation, that the protein C deficiency induced by vitamin K antagonists is causing additional microvascular thrombotic lesions. So I would be careful with warfarin, especially with early onset warfarin. If these patients are then stable after 2 weeks, warfarin is probably fine. But as long as the dimers are elevated and the platelet count is low, the entire experience in HIT hints towards that warfarin might be really dangerous and might worsen the situation. And for the low-income countries, I by myself are involved in some projects in sub-Saharan Africa, and it's amazing how widely the direct oral anticoagulants are distributed in these regions. So they are probably a reasonable treatment options because they are available in many countries, even in many low-income countries in the world.
James, would you like to comment as well?
Yeah, sure. So I think maybe back to the initial question of the SYK inhibitors. I mean, I think that Steve Watson's published some stuff recently just on in vitro, some of these inhibitors having activity regarding blocking the FC-mediated activation, which is perhaps, as Andreas has said, not completely surprising. I mean, clinically, I guess the issue would be, you know, the IVIG experience thus far is pretty positive in this condition. You know, I think that the response we see clinically, you know, not in all cases, but generally speaking, is pretty good. So I think in that way, I think it'd be hard to now get the relevant data at this point to try and roll out these drugs. I think the other question came up was about the vascular bed specificity. So I think that, you know, I'd probably tend to agree with Liz about there's possibly an important role here for shear or the shear environment, and especially the data that Andreas and other groups are now presenting about the role of neutrophils, right? Because neutrophils obviously tend to operate and are recruited preferentially in low shear environments. So it's conceivable that that's in play here. In terms of the bacteria, Liz, I think that certainly could be a role in the gut. I think the idea about, abdominal vein thrombosis and bacteria and the immune response there has been around for a while. But again, all this issue of vascular bed specificity thrombosis, that concept I know has been around for a long time. I don't think anyone's conquered it. Whether this will be a stimulus for people to really get into it, I'm not sure, but it's still an open-ended question. And I guess the other thing to say is not all patients present with CVST or abdominal vein thrombosis, right? They still get standard DVT, PE, or indeed they have clots in multiple areas at the same time. So it really is still something which I think we don't have a really good handle on just yet.
And maybe an interesting question for the immunologist and virologist. So what that came up here several of the questions. One is the timing of the second dose of vaccination, and then one general question which I always wonder: why do we see these VITT cases only after the first injection? Would we not expect that the second injection causes it much more often?
Yeah, in fact, that was the question I was going to ask if I had a chance to ask a question. Why are we not seeing it with the second dose? The timing of the second dose from the vaccine standpoint or from the virology and immunology standpoint is that it is probably better to have a longer interval because of anti-vector immunity. So you want that to not to interfere with your second dose. So unlike the mRNA vaccines and activated vaccines that are typically given 3 to 4 weeks apart, the adenovirus vector vaccines are being either given as a single dose with the Janssen vaccine, or if they're given in 2 doses like the AstraZeneca version, would be a longer interval is better. And that's just from the immunogenicity of the vaccine. And of course, everything was done fairly rapidly in terms of figuring out what the best dosing strategy would be. And we are still learning, as you know, about whether we need an additional dose as antibodies wane. But certainly in the initial phase, it's because of anti-vector immunity concerns.
Yeah. Maybe Andreas, if you would like to address this question about the second.
Yeah, it's pure hypothesis. The first reason I assume that the second dose causes less immune response is that clinically, the second dose of the AstraZeneca vaccine is much better tolerated than the first dose. Those shivers and other fever and other adverse effects seen during the first 24 to 36 hours are typically much more pronounced during the first dose than during the second dose. And I spent quite some time in my talk hinting towards the co-inflammatory danger signal required to stimulate these marginal zone B cells. And this co-inflammatory stimulus is much less pronounced during the second vaccination dose. So why is it much less pronounced? Now, I'm not a virologist, but I have learned now that hexone proteins and other viral constituents bind to some of the innate immune system receptors. And Dr. Rao just indicated that there's anti-vector immunity. So during the second dose, there will be a lot of individuals have antibodies against these viral proteins and probably remove them from the circulation because before they can stimulate the innate immune system. Now, even more speculation. If the complexes of viral constituents and PF4 are the triggers forming the antigen, then the complexes can no longer be formed when the antivirus antibodies have removed all these constituents from the circulation rapidly, and together both effects may contribute to this very clear observation that the second dose is much less associated with the severe adverse immune reaction than the first dose. But again, no animal data, but for me at least, it sounds logic and would make sense.
Maybe I give the panel members a chance for another statement or a question as well. Liz, do you want to start?
So there's plenty of questions on the
yeah, if you want to address some of them.
Yeah, well, just I put to the panel something I'd like to know. Do we have any knowledge around ethnicity and preponderance for VITT? Are there any studies out there coming through? Several people have asked this question and there's great detail. So Dr. Phil Choi, are there emerging trends in the German data? It seems lowest in Asian reports, for example, Korea, and highest in Northern European, for example, Scandinavia. So I think you alluded to the answer in your talk, but
yeah. I have no idea, and the German population does not have the ethnic diversity like the Australian population, and there are two things which overlap. The one is the reporting rate of adverse effects, and the other is the ethnicity. And it is extremely difficult to compare prevalence data between different regions, even between the US and Germany. There are so many differences in the healthcare systems that we are never certain which effects we are currently measuring. And Australia might be the ideal place to give an answer to this, because you will have larger numbers of inhabitants of different ethnicity within the same healthcare and within the same reporting system. And this might help to answer this question.
So Liz, it's you, and if I can comment. So at least in Australia anyway, amongst the reported cases that's been listed by the TGA and so on, and certainly, you know, we do the testing on all the cases, ELISA and functional testing up in Sydney. I have to say we struggle to see an Asian sounding surname in all of the reported cases. So that's an interesting observation. There was a population type publication with quite good data linkage from the South Korean group, reporting that the rate of VITT in their population was about 0.2 per million AZ doses, which is, you know, remarkably low in comparison to Western rates. We know India uses a lot of adenovirus and AZ type vaccine, and surveillance aside, is curious that they are reporting ITP, but they're not reporting the same number of cases of VITT that's been reported elsewhere. So that, you know, observationally, there may be differences in racial origins, whether or not that's, you know, polymorphism or changes within the receptor of the F2C gamma. I think it's worth exploring. And, you know, as Andreas has said, you know, in Australia, we've got quite a heterogeneous population, very multicultural, and we've got an excellent surveillance, vaccine surveillance system. So I think it's something that we will be and should be looking at.
Just on that, Ewan and Andreas, can I ask, is there any data on Hit and ethnicity in that context? Not to conflate the two, but there's obviously some overlap. And is there any data around that?
No really reliable data. Also, the feeling that HIT seems to be less frequent in Asian populations. But again, healthcare systems are different, population exposure are different. The indications for major surgery are different, and it's very difficult to draw firm conclusions in the moment. But at least there are hints towards a lower preponderance of an anti-PO4 response in Asian populations.
Okay. we are close to the time. So I think on behalf of everyone, I would like to thank the speakers for their fantastic presentations and the panelists for their important expert contributions and especially lively discussions. I also want to thank Leonie Cullen and Sarah Makula for their help in organizing and running the webinar. And just as a closing comment, I think as scientists, we can be proud of the extremely fast and successful development of COVID-19 vaccines. It's really a testament to what immediate difference science can make to all our lives and to our economy. The vaccines are so successful that we can state at the moment that COVID-19 will be only remaining a deadly threat for the unvaccinated. And as such, we can only urge everybody, especially with the current increasing case numbers here in Australia, to be vaccinated as soon as possible. And this message concludes our webinar. Thank you very much.